My name is Monica Ultmann, and I am a developmental behavioral pediatrician and director of the Center for Children with Special Needs at the Floating Hospital for Children Tufts Medical Center in Boston. I'm happy to join you and thought you might be interested a bit in knowing how I became involved with Reach Out and Read. In 2006, I began the St. Louis, Missouri Coalition of Reach Out and Read, and shortly after beginning working with that coalition, I realized that practitioners had many tools to work with typically functioning children, but with the ever increasing number of children presenting to primary care with developmental disabilities, the amount of information for the primary care practitioner was not as available. So I began developing information on several developmental disabilities, which we'll cover later. And when my husband and I moved to Boston in 2009, I began working directly with the National Center to develop the materials, which were published in 2010. We're currently redoing and adding to the materials, and those should be ready for the coalitions in spring 2018, and will include videos actually working with children with various developmental disabilities and their families. So today we're going to talk about emergent literacy, using books as tools for developmental surveillance, promoting literacy in infants and children with developmental disabilities, and we're going to review 2 case studies where we'll talk about using the material. Emergent literacy is the steps the infants and children progress through as they master the complex requisites for reading and writing. Among these, it is important to know that emergent literacy is a very complex process, beginning at birth and ongoing through an individual's lifetime. Additionally, it involves many factors in a child's life, including the interactions with families and the attachment that are formed with significant people in the child's immediate environment. A term called scaffolding of child development is an important term to know and to interact with families, because as a child sees various interactions with the adults in their environment, such as reading books, that adds to the developmental ladder that a child can begin to build on. Emergent literacy involves all domains of child development, from early verbal and nonverbal interactions to fine motor and gross motor tasks, to the ever important nonverbal, expressive, and pragmatic language skills, so that the child is constantly gaining concepts to help them with acquiring skills in reading and writing. There are 3 types of emergent literacy: that which is constructive, and through communication and exploration, the child builds internal concepts about his environment; functional, that they develop skills to function in their daily environment; and interactive, that their construct involves feedback from adults and other children in regard to both language and play. Components include reading aloud, which is the most important factor laying the groundwork for a child's later love of reading. The concept of a symbol representing something that has functional meaning to the child. Emergent writing, which develop concurrently and a child learns from demonstration and experience. And the literacy environments provided in the child's environment, such as adult interactions, role modeling, or that scaffolding that we talked about, availability of books and writing materials in the child's environment, and the viewing of adults who value those kind of interactions and a child's reading efforts. For children with developmental disabilities and the families who you see who are attempting to encourage them, there's a quantitative and qualitative divergence in experience, which often limit the progress of emergent literacy acquisition. This can include atypical social, emotional, or cognitive development, altered communicative intent with limited receptive, expressive, pragmatic, or interactive skills, physical constraints, which can interfere with motor planning or mobility issues, and attentional challenges. Environmental implications for families include significant time devoted to physical care and therapies, attachment issues with a caregiver, and parent-child interactions. The degree to which the caregiver has insights, the attitudes they have, and their involvement with their child, and misunderstanding or even underestimating a particular child's abilities. Some of the other challenges include maintaining individual and joint attention during storybook reading, pointing to pictures or to words, the ability to hold a book, understanding a story content due to delayed language development, participating in rhyming or retelling, physical limitations such as holding and controlling a pencil, holding and controlling magnetic letters or puzzle pieces. We often talk about utilizing books in a primary care practice that help a practitioner with developmental surveillance. So as you give a book to a child, what are the different things that you can notice that might be tip-offs? So for example, look at the child's eye contact. Is the child paying attention to the book and then referring either to the parent in the room or to you as you're interacting with the child? How does the child attend to the book? Do they form joint attention or triangulated attention with a caregiver? And are they able to focus on the content on the page? Does a child bring a book that you gave them to the adult in the environment for shared enjoyment if they're in the age in which they can walk toward the family? How's the child doing in terms of their language? Is their expressive language showing babbling? Are they able to gesture or point? Can they understand directions? Or if you say, point to the ball, can they point to the ball? In terms of the pragmatics, do they have the social context in language? If there's a funny picture, do they laugh? Or do they understand that you are wanting to share the book with them? And when they're looking at the book, do they have any atypical language, such as echolalia? If you say a cow, do they then say cow, cow, cow? Observe how the child's fine motor skills can influence the handling of the book. How do they hold the book? Can they turn the pages? And do they have preferences for particular aspects of the book? If the book is being shared with the adult in the room, are they able to show turn-taking skills? In Reach Out and Read practices, there are many unique opportunities to interact with children and families where there may be a child with a developmental disability. As Aurora practice is already focused on encouraging emergent literacy and is geared to distributing books at well child visits. If we assume that about 8 to 15% of children are diagnosed with a spectrum of developmental concerns and disabilities, primary care providers in rural practices are in a unique position to help and encourage families with their child's cognitive progress and suggest approaches to fostering emergent literacy. This is called the Developmental Disabilities Literacy Promotion Guide. We looked for guidance to families in 7 areas: speech and language problems, autism spectrum disorder, intellectual disabilities, cerebral palsy, low vision or blindness, hearing loss or deafness, and attention deficit hyperactivity disorder. In the redo of these materials, we're adding learning disabilities, as we now recognize that there are red flags prior to the age of 5 in children who are at risk for later development of reading difficulties. We provide information that you can use with your children for infant and toddlers, preschool and school-age children. And then we look at suggested books in each developmental disability, both for infant and toddlers and for school-age children. So case 1 is Allison. She's a 3-year-old child, and she's been followed by the same primary care practitioner since she was a newborn. At her 2-year-old checkup, She had 10 single words, but no two-word phrases. She showed good joint attention, pointing, and emergence of imaginary play as she was feeding a doll that her mother had brought to the office. Her hearing evaluation was normal, and as a result of the fact that the primary care practitioner saw that she had only developed 10 single words, she at that time was referred to her state early intervention program. At her 3-year-old checkup, she had been receiving services through early intervention, and at that point, she was transitioning to the public school preschool program. She had a vocabulary of 50 difficult to understand single words, and she infrequently put words together in phrases. You handed the book to her. She had good eye contact. She pointed. She showed some impatience and fidgetiness, did not enjoy listening to the story read to her, but loved to turn the pages. Her parents raised concerns about Allison's short attention span, and the only time she was noted to sit longer than 2 to 3 minutes was when she was watching her favorite TV program. She did best with 2 to 3 words to the page, and when she could manipulate or touch pictures on the page. And when she became inattentive and distracted, there were pull-out figures embedded in the page, served to redirect her and draw her attention to the book. So, speech and language impairment is the most common developmental problem affecting children, and that almost 10% of children are diagnosed with speech and language disorders. It covers a huge spectrum from simple speech and language to global communication disorders, intellectual disabilities, and autism spectrum disorders. And it can encompass difficulties producing speech sounds, such as Allison has, receptive or expressive learning disabilities, or expressive disabilities, and can reflect comprehension, language processing, and pragmatic skills, which are the social context. The most effective intervention, beneficial for later school functioning, are early intervention, so that the earlier one begins a child with early intervention, the better the outcome for later development. Certainly, hearing is important and should be evaluated in any child where there is a concern about language delay. So we want to encourage literacy by interacting around books and reading, repeating strings of sound, talking to a child during daily routines, naming objects, people, drawing attention to print in everyday settings, introducing new vocabulary words, reading on a regular basis, using rhymes and sounds, rereading and rereading a child's favorite books so that they can hear the sounds, focusing on a child's attention, providing multiple short breaks, a variety of materials for other related activities, and encouraging a child to talk about the activities that they are doing when they're writing and drawing. These are the handouts that are available currently in the 2010 version to give to parents to help them to understand their child's speech and language problems. And we have a handout available for all 7 of the developmental disabilities that we discuss. So if the child has, if you have concerns about the child and you would like to provide the parents with something to take home, which is always the most effective thing, you can use these. And it talks about generally helping children with developmental disabilities love books, tips for reading both with infants and toddlers and then with school-age children, suggestions for books for preschoolers and school-age children, and then suggestions for the parents on reading that they can obtain to help them understand their child with developmental disabilities. And then we have also given them websites so that they can begin to understand more. These are written in the middle school or so range of literacy, and so hopefully these are accessible for children and can either be given to the family as they leave the office and either reviewed by you or the physician's assistants, nurse practitioners who are in the office. And I think that these are very helpful information to share with parents. This is the handout that we give to families with attention deficit disorder, and each of the handouts follow exactly the same design and are to provide information on reading with children, in specific books that are helpful for families, and then information for parents and websites that can be helpful. And I think all of these, as we look through them, are still absolutely pertinent for the current moment. Case 2 is Rosanna, who's a 24-month-old girl accompanied to the visit with her healthcare practitioner by her mother and grandmother. The family recently moved to the Bronx, which is a borough of New York City, but Rosanna had previously been followed by the same healthcare provider since she was 6 months of age. You have seen her for the first time during a brief sick visit 2 weeks prior to this appointment. Rosanna's mother is 18 years old, lives with her extended supportive Puerto Rican family, and Rosanna is spoken to primarily in Spanish, though she does hear English in the home and watches cartoons in English. The last time Rosanna was seen by her previous primary care provider was for her 15-month checkup, and at 24 months, you have a brief summary of that visit. Her mother came alone to that visit and did not express any concerns about Rosanna's development. She reported that Rosanna had good eye contact with the family and other familiar people, says a specific mama, and points, was babbling, no single words, did not look at the examiner, and vaguely gestured with her hand. Concerns were expressed to her mother about aspects of Rosanna's development and that she should be evaluated again at her next appointment in 3 months, which would have been at her 18-month checkup. Unfortunately, because of a family trip and extended visit, they missed that checkup. And Rosanna's grandmother expresses several concerns at this point about her development. Her delayed language development, she mentions that she repeats words she hears on TV, picky eating, lack of interest in children, always carries a toy in her hand, rarely has tantrums, but when she does, her grandmother notices she flaps her hands, and she has to fall asleep covered by her favorite blanket and tucked under her mother's arm. You yourself try to engage Rosanna and ask her mother whether they read books together. They try. Her favorite book is Goodnight Moon, and they read it every night. She loves the bunny. So you have a 2-year-old who clearly, since the 15-month visit, has developed delays in language. At that point, she might have been saying a few single words, but she was accompanied with her 18-month visit, her 18-year-old mom, and then they did not show up for their 18-month-old visit because they were in Puerto Rico. So looking back, if you had been the practitioner at 15 months, you might have thought, as the practitioner did, about encouraging that 18-month visit. But certainly at this 24-month-old visit, you might think about screening the child with the modified MCHAT, recommended by the American Academy of Pediatrics, to see if there are red flags for autism. Because as we're looking here, there are obviously aspects of her environment, such as a vague pointing, repeating words, that you would be concerned whether that might be present. If you do administer that and you're concerned, you want to use this opportunity to talk to Rosanna's mother and grandmother about your concerns. Certainly at the beginning, you want to emphasize Rosanna's current skills. The fact that she's gained language, the fact that she's interested in books. Certainly acknowledging the strong family support, the family to the visit, is very important, and affirming the concerns that the grandmother expresses. Talking to Rosanna's mother and grandmother about the screening results is very important. And introducing your concern that Rosanna may be showing signs of autism, why you are concerned, and what you notice in the language that they can understand. You want to emphasize that your concerns are not a confirmation of her autism diagnosis, but an indicator that you need to look further. You want to discuss the importance of further assessment with a formal hearing and vision assessment, a referral for subspecialty evaluation, and whether that subspecialty evaluation is to a pediatric neurologist or a developmental behavioral pediatrician or neuropsychologist may be dependent upon where you are located and what the possibilities are for referral. You also want to refer Rosanna for early intervention evaluation and services. In many states, if the primary care provider provides a letter with a diagnosis of autism, the child at that point is eligible for the higher level of services, including applied behavioral analysis. So I encourage you to know what your state recommendations are and provide that letter to parents if you feel comfortable doing that. You want to explain to the family that Rosanna's next checkup would typically be at 2.5 years, but that you're available for questions and would like to see her in 2 months so that you can see how she's doing in early intervention. So what's important is always to listen to parent concerns. Monitor via ongoing surveillance and pointed screening tools. Consider the risk factors. In the case of Rosanna, the adolescent young mom is a risk factor, and having grandma as an ally to make sure that they follow up on your recommendations is a very positive factor. Providing parents with an honest assessment of your concerns that they can understand and following through on the referral that you've made is very important. And if ever in your practice for children under than 3 years of age you're unsure, refer to early intervention. They will screen a child. If they feel the child falls at a certain level of delay, they will immediately start providing services. If not, they can then provide follow-up screening in a short period of time. So the potential for developing literacy capabilities in children with autism spectrum has historically been underestimated. Sharing reading time, literacy-rich environments, modeling literacy activities, and access to materials for the development of critical emergent literacy skills in young children with autism and other developmental disabilities is so important. And the literacy development in children with autism or other communication delays are influenced by factors similar to children who are typically functioning. Of special note, though, when children are identified with sensory issues, incorporating sharing reading time as an important part of a daily routine is very helpful. Using rhyming, alliteration, and singing as part of reading helps children with language development. Books with a tactile component, such as Pat the Bunny, for children with sensory issues is important. And even looking at books with 2 to 3-year-olds, such as the Baby Faces books, where a parent can explain and teach a child about sharing emotions. This baby has a happy face, this baby has a sad face, are important. Understanding that capturing the child's attention by books that have lower word content on the books and more pictures might be helpful. And introducing the concept of social stories to parents to introduce children to new activities, such as going to the doctor, going to the dentist, are also very helpful for children with language delays. These are the handouts that we have developed for children who may be diagnosed with autism spectrum disorder. If you feel comfortable in your practice making that diagnosis, don't hesitate to hand these out to families. If you don't, it's a wonderful tool to use with families once they return to your practice after they've seen a subspecialist. And again, the care of children with autism spectrum disorder and the knowledge that can be conveyed conveyed to parents with their children really helps children as they move along the developmental spectrum. In these books, in these pages, we've also included books that are helpful for siblings as they learn about their brother and sister with autism. These are great age-specific books to provide to families. And again, we have a larger number of websites that parents can look at that provide a myriad of information. And in the new editions, we'll be providing websites in multiple languages since these have been developed since this material was produced. So overall, in terms of anticipatory guidance as primary caregivers, we want to always keep in mind the activities that families must do to meet the needs of their children with developmental disabilities. Meeting with schools, developing IEPs, attending therapies, and the medical needs, especially of children with complex medical needs, to find the mutual pleasure of shared reading, storytelling, and playing interactive games. Encourage communications with families. When they're cooking, encourage that families to involve the children and to talk through either mixing things, counting eggs, also parental modeling of reading and writing, and creating literacy-rich home environments are very helpful to children. Acknowledge what the parents are already doing to promote early intervention in their child. I've seen families reading in standards for children with cerebral palsy, or rhyming activities when they're doing range of motion activities with their children. It's really important, especially in children with visual or hearing abnormalities, to correctly position the child to encourage joint attention when parents are reading with their child. Very important to direct parents to early intervention programs and disability-specific resources where they can learn how to engage their child in language, literacy, and play activities. Encourage adaptive approaches and tools to meet a child's specific needs. So for example, in a child with visual impairments, using Velcro to help a child understand a circle, or encouraging children to point to pictures if they're having difficulty establishing pointing. It's been wonderful to share this time with you, and thank you so much for your attention.